speaker, as an invited speaker here. So my talk is kind of built out of two parts. So the first part, as you can see, hopefully, no, it doesn't work. No, it works. Okay. So the first part is more scientific data, and the second part, as you can see here, is more a practical recommendation, a practical concept. But the connecting word is maintenance, maintaining exercise programs during COVID pandemic in Germany, and maintaining physical activity promotion and exercise intervention throughout the whole course of treatment, from diagnosis until survivorship. So in Germany, we have a lot of centers that are treating childhood cancer patients, over 60 centers, different centers, and we are in the happy situation that we have more than 30 exercise programs that are provided for all these patients. So some of you might remember the COVID survey that my colleague Dominic Gaza presented last year on this Congress. And I will just give a short review of this and then get on to our second survey. So we wanted to know what is the impact of COVID-19 on exercise programs throughout Germany. We did an online survey in January and February 2022, and we contacted via the network Active OncoKids 33 eligible providers, were hospitals and universities, rehabilitation facilities, and non-clinical institutions. And the focus was on program delivery and research projects. The response rate was quite high with 82%, and 85% reported restrictions. One interesting information and result that made us really happy was that 6 programs were implemented during pandemic period. And you can see here first the link or the QR code to the poster. Dominic provided this. Thank you, Dominic. And please just scan and have a look at it. And you will see in the graph that during the waves, the pandemic waves in Germany, where the incidence was really high, the programs got sometimes canceled in the beginning or paused and restarted. Some were constantly available. And as you can see here in the 4th wave, no program had to be canceled, and a lot of programs were available the whole time. So that was a good information. And 1 year after, we wanted to know what is going on now. How are the restrictions? So we did a second survey and kind of a follow-up, and we got new insights. So the second the focus on the second survey was the development of exercise program availability and new approaches. What did we learn from COVID pandemic and from adoption of programs? We repeated an online survey, and we contacted all the providers who answered in the first survey. And the focus was on the decline of restrictions and the continued approaches. We had a response rate that was unfortunately a bit lower. 70 providers answered, and we had no rehabilitation facility that answered our questionnaire. You can see here the providers' responses named or provided in colors, and it's not a surprise that the consulting institution, it's the network Active OncoKids, so just one part, and the acute therapy, maintenance therapy, and aftercare. It's altogether, it's of course not 17, because some of the providers offer exercise program during acute treatment, during maintenance therapy, and during aftercare. The institutions were mainly hospitals and clinics. Some were universities, researchers who went into the hospitals. One was a provider that offered programs not in an inpatient rehabilitation, but associated to a rehabilitation center, and the consulting institution, the network Active OncoKids. So these are unpublished data, but the manuscript is in progress, so I hope we can finish that soon. As you can see here, we have, fortunately, a decline of restrictions during or since the last survey. So the full shaded column is or says the conduction is comparable to a pre-pandemic level. That's quite a lot. We are really happy about that, almost 60%. The shaded part of the column is what we need to achieve during, hopefully, this year. So everything is comparable to the pre-pandemic level. The most, or the highest reductions or restrictions are still in the active and the acute therapy. So that's not a surprise. And during maintenance therapy, because this is the most vulnerable phase of treatment, and we have to keep an eye on our patients there. We still have some restrictions, some persisting restrictions, like considering common hygiene requirements that are still necessary in many of our hospitals. Some exercise programs only train with selected patients, do single interventions, only on selected locations, but it's, as you can see here, really getting better. The second question we asked was a retrospective question. So how did the providers perceive the impact of the restrictions? And you can see here again, the colors are the same. So acute therapy is orange, maintenance therapy is yellow, aftercare green, and purple for our network active OncoKids consulting. So the circles show the proportion within the complete sample. And as you can see here, the clinical restrictions and governmental restrictions were considered with the highest impact. That's not a surprise, I think, but it's really good to see that all the other restrictions, like a lack of final resources or sick employees due to COVID pandemic, fear of infection of clinical staff by clinical staff, and fear of infection for the patients and the families, were considered only medium or quite with low impact. So probably these quite strict restrictions from the government and from the local clinic really, yes, they worked and they were effective, and they kind of gave some safety. We asked for new approaches that were developed during pandemic, and we wanted to know in which settings they are still used. So please consider we deleted the abstentions here. There were 6 abstentions. They did not answer at all. But as you can see through the whole graphic, so all kinds of different approaches are still used. So online trainings, videos on demand, single trainings, a lot, although the providers wish to reduce this and go over to more group trainings for social contact. So hiring or giving material to the patients during acute treatment or during aftercare is still common. Providing workout plans for sessions at home, outdoor sessions, and phone calls for consultation. We further asked for the future perspective. How did the providers estimate the future perspective of these approaches? And as you can see here in the shaded columns, almost every kind of new approach is considered maybe even more effective or useful in the future, except for the single trainings, because probably we are happy to reduce them. But all others are really happy to use them maybe in the future even more to increase the reachability, maybe to rural areas. And as we heard in the talk Nicole gave for Amanda, Zoom sessions or digital provision of exercise programs might be some really big part of our future. So to summarize, and for a little conclusion, we have developed a lot of online offers or provided some more to a more higher extent. People stated that we had an increased flexibility of training sessions, so more flexibility, how to provide it, what to provide, etc. Expand our phone consultation, workout plans, and what is really important, patients showed a high demand and a high acceptance of these adaptations to the situation. Sometimes it was the only possibility to exercise in the hospital, and we reached a lot of more patients and maybe survivors than before. So it's an impact on the patient level and on the design of exercise programs. Second part is an impact on the social level and within the multidisciplinary teams. So implementation and conduction was feasible despite considerable barriers. So 6 programs were implemented during COVID pandemic in Germany. That's quite good news. Furthermore, attention within the hospital and within public was increased, and it was given a high appreciation by the multidisciplinary team because exercise programs were rated as really necessary during treatment. So we also had free text answers, and as you can see here, and that leads over to my second part of my talk, there was a high motivation for restructuring, optimizing, and professionalization of exercise programs during this part, because we had to adapt a lot, we had to get creative, and just to cite 2 papers that are so not about tidal cancer patients, but about cystic fibrosis from the UK. So program delivery via digital tools. And on the other hand, for adult cancer patients, the question was asked if a virtual supervised exercise intervention is a sustainable alternative to in-person exercise sessions. So leading over to my second part, I will show you our program, the structure of our program in Munich. And I'm sure that many of you who are providing programs during the whole course of treatment have similar approaches. So I will be really happy to discuss this and to get information from your programs to what tools you are using. So I will show you what we are doing, the steps, the focus, and the tools we are using. In the first stage, during diagnosis, we try to get initial contact very early during treatment, just shortly after diagnosis, to start early. We are introducing the program, telling the patients and the parents what we will do, how it will work, and how they can get in contact with us. We are doing an exercise anamnesis to get information what the child's experience is regarding physical activity and exercise, because we think this is important to build up the program during treatment. Furthermore, we give information material like our training manual and our flyer, how they can get into contact with us. So this takes about 20 minutes. Sometimes we already start with the first intervention right after that. Second step is acute treatment and the provision of individual physical activity promotion and targeted exercise therapy throughout the whole acute therapy phase. Due to this anamnesis, we can build up a really individual program aligned to the experiences and wishes of the patients. We can provide continuity over the whole course of treatment, and it's all about support and care in this phase. We're trying to exercise 2 to 3 times per week with every patient for 20 to 30 minutes, and we need around 5 minutes for documentation, because documentation is a really important part of our program. We have soon we will be again 4 people in our team, and we are not dividing the patients between us. So everyone is doing exercise intervention with every patient. So documentation is really important. We do a kind of a progress monitoring. That means that we have a look at our anamnesis, and then we document how is the motivation, what has changed, did the patient have any surgery, any new physical impairments, etc. Third step, maintenance therapy and early aftercare, very sensitive phase. Our aims are advice how to be physically active after the active therapy, acute therapy. We will provide a perspective for our patients, and we will do a transfer to reintegration into support structures. And of course, some physical activity offers as well. we have a kind of a closing meeting. I'm not sure if this is the right expression, but I will explain. Maybe there's a better term for that. So we are doing a talk at the end of treatment, at the end of acute therapy. We're talking about what is their perspective? What do they want to do? Where do they think they need help? What are their wishes? Should we talk to their teacher, physical education at school? Should we get in contact with a trainer? They want to start in a sports club, etc. So just a recap and a preview what is happening during the next few months. This takes about 30 minutes. Then we have an evaluation. We had a pre-run or a check run, and we are starting over again soon. We try to evaluate our program regarding contents. How often did the children do exercise? Should it be more often or less? And what did the parents think about it? What could be improved? This takes about 20 minutes. We're writing an exercise letter, and already did that with Miriam in our former hospital where we worked together. And I restarted this because I think it's really important. And we write down there, it's comparable to a physician's letter. So we write down medical information, physical impairments. We write down the number of exercise sessions we did, the duration, the content. We can add diagnostic tools like motor performance testing, perspective, and so on. And this letter is for the treating physicians in the hospital, for the physiotherapists, and we want to give it to the families, because they can hand over to their pediatrician, to their physiotherapist at home, to the rehabilitation facility they are going, and the information flow is a lot better than with phone calls, and no information gets lost anymore. Furthermore, we have an intersection management. So we have a new project called Lift Up, and it's about increasing quality of life and physical activity for patients after treatment. So we have a coordinator who's helping them to do reintegration to sport structures, to get back to physical education at school, to find out new sports club, new possibilities to exercise and to maintain an active lifestyle. So last but not least, the long-term aftercare. We do a lot of exercise counseling. We try to support the engagement in an active lifestyle, and we try to meet our patients during follow-up appointments. We provide support if needed and contact as needed. This takes about 5 to 20 minutes, depends on the needs and depends on how much they want to talk, if they have problems or not. We just ask them, is everything okay? Do you want to get help from us or not? How physically active are you? And that's quite good. So to summarize, we try to be continuously addressable and give support during the whole course of treatment. We use standardized milestones. We did that before, not like we do it now, and after our restructuring. We're really happy about this because no information gets lost anymore. So it's kind of a checklist. We provide a careful and assisted transition, especially during the sensitive phase of end of acute therapy and aftercare or maintenance therapy. We try to have a guided information flow, that no information gets lost, information gets to all of the people who need this information. And we use follow-up appointments to get to know how our survivors are physically active, and it doesn't care if they finished treatment 1 year ago, 2 years ago, 5 years ago, or 10 years ago, and we don't even maybe know them because our program starts around 6.5 years ago. So thank you for listening. Thanks to my working group, our cooperation partners and colleagues, to the presidents of this conference, and of course for our financial support. So this is just our care program, no study procedure, but we think that this structured program really helps us to provide the best physical activity program and exercise program we can do for our patients.